understanding tricky plan issues, HSAs, multi-state plans, deductibles, and more. Joanne Volk will be presenting this material. Joanne comes to us from the Center for Georgetown Health Policy Institute. And welcome, Joanne.
Thank you. And thank you for having me present this material. I'm going to go through a presentation today that you may use in understanding how to consider your plan options and choose the best one for you, how to use your benefits then and pay attention to the rules that matter, and what to do if there's a problem with your plan. Okay. Selecting a plan is one of the most complicated things you may have to do. It's a multidimensional product that is not a simple little small appliance you can just sort of size up a few factors and order online. It is has a lot of moving pieces in the plan itself. It requires you to understand what some of your healthcare needs may be in the year ahead, and it can be a very complicated and emotional process. But we're going to walk through a couple of things to consider today. I'm going to talk about the different types of plans that you may have to choose from, deductibles and other cost sharing that may apply in the plan, and networks. Briefly, looking at the types of insurers, there are really two main types, and the one you're probably most familiar with or will see the most often are the commercial health insurers like your Aetna, United Healthcare, Blue Cross Blue Shield plans. They also include a couple of things I want to point out that may be options in the marketplace. There are co-op plans, which are member-owned plans that are a creation of the ACA that were intended to increase the competition among insurers and make sure that there would be enough insurers offering products in the marketplace. I guess the thing to pay attention to in the co-ops, they're not everywhere. They are only in a limited number of states right now, although they're starting to grow between year 1 and year 2 in the number of states they're participating in. And member-owned does not necessarily mean they're going to be the best and lowest cost product out there. It's just the way they're organized, and you'll still have to pay attention to the details of that plan to know whether or not it's the right one for you. The other kind of new option that's available in marketplaces are former Medicaid managed care organizations that were previously just offered to Medicaid patients or consumers, and now are also available in the marketplace. And in some cases, this was supposed to help with transition issues if someone changed eligibility over the course of the year from income that qualified them for Medicaid to income that qualified them for tax credits. It was supposed to make it easier for them to stay with the same insurer and the same providers. That may or may not be the case, but it's a new offering in the marketplace. And then the second major chunk is health maintenance organizations. And in this case, I'm talking about the integrated insurers, where the insurer and basically employs the doctors and owns the hospital. So like a Kaiser Permanente, where it's all the physician and the hospitals work for the plan itself. There are different types of products that these insurance companies can offer, and we'll run through some of them here. The HMOs, health maintenance organizations, limit enrollees to getting care in-network only, with only a couple of exceptions. You have to work closely with your primary care physician, who you establish a relationship with. They're responsible for managing and coordinating your care. And you have to get a referral from your primary care physician to see a specialist or get additional services like diagnostic tests or labs. And in some cases, if you don't get that referral, the service is generally not covered. So pay attention to those rules and work with your primary care doctor if you're in an HMO. Some of them come with what's called a point of service option, that POS option, which means that you may be able to go out of network with your primary care doctor's recommendation for certain services. But again, there's going to be limits that apply to that, and it's going to be specifically marketed as something that has a point of service option. The second major piece here that the product type that we're talking about here is preferred provider organizations, the PPOs. These plans contract with the providers to create a network of participating providers. And if you use one of those participating providers, you'll be considered getting care in-network, and you'll pay lower costs. You can still choose to go to doctors out of network. Unlike an HMO, you can go out of network, see doctors and hospitals, but you will pay a higher cost out of pocket for that care. You generally don't need a referral from your primary care physician to see a specialist. although the specialists themselves may require one and say that you need to get that referral before they'll see you. Another major product is called an exclusive provider organization, and this is really a hybrid of HMOs and PPOs, so that they do contract with providers so that there's a network, and they won't reimburse for any care received at a network, like an HMO, but you don't need to work with your primary care physician to see a specialist or get services. You can move around the providers as you wish, as long as you stay in network. Another couple of product types I wanted to talk about here are the MSPs, or the multi-state plans. This is another creation of the Affordable Care Act, again, to sort of increase competition and make sure there were a sufficient number of insurers to offer plans in the marketplace. The thing that's really important to know about this type of plan is, despite what the name would suggest, a multi-state plan, in fact, they don't necessarily cover providers in other states. They are still generally limited to the boundaries of the state. I mean, any given plan may cover out-of-state coverage or services in some cases, but that's not necessarily the case with the MSP. There's also HSA-compatible products on the marketplaces and sold outside the marketplaces too. I'm going to talk about those in more detail with my next slide, but these are high-deductible health plans that qualify for pairing with a health savings account. And then finally, there's something called accepted benefit plans, and this is a category that includes plans that are not fully insurance. So they may include, for example, hospital indemnity policies that pay a fixed dollar amount per day for if you are hospitalized. It could include discount plans that just basically say that you can see providers at a discounted rate. It may include short-term non-renewable policies, which means that the policy lasts for some period of time less than a year. It could be 364 days, but that means it's short-term and they don't have to renew that coverage for you. Or there are even plans that cover a specific disease, like cancer-only policies. All of these things I just described, accepted benefit plans, are not considered insurance. They don't have to meet the insurance rules that you typically think about with the Affordable Care Act, like the limits on out-of-pocket costs and the benefit standards. And they also don't count as minimum essential coverage, which is what you need to have to check your box on your taxes to say you have coverage that meets the individual mandate. So you really have to be careful if you're buying outside the marketplace to know whether or not you're getting one of these plans that won't provide you with all the protections and won't meet the mandate.
So how will I know what type of plan I actually have, or whether it's an HMO or a PPO?
Well, in the case of HMOs and PPOs, honestly, these used to be very distinct lines, that there was an HMO product and there was a PPO product, but increasingly the lines are sort of blurred these days. And so even in the example of the HMO plus the point-of-service option, it's really, in-network, out-of-network, they're not hard and fast rules anymore. And what I would urge consumers to do is actually pay closer attention. Even though the plan documents may say in the title that it's a PPO or an HMO, what you really need to pay attention to are the rules for getting care at a network and the costs associated with that care. So that's what you need to be focused on, is can I see providers at a network, and if I do, will it be covered and at what cost to me? I will also say that on the accepted benefit plans, they are supposed to notify you that they don't meet minimum essential coverage, which is your clue that they won't be sufficient for you to meet the individual mandate, and also that they don't have to comply with all the consumer protections of the Affordable Care Act.
So do you think those accepted benefit plans would have, in bold on the top, like we don't meet the requirements, or?
No, they may not call it out, and I will say that it's supposed to be there, but these are sort of by definition not insurance, and sometimes rely on tricking people to get enrolled, and they think they're getting more than they are. So it's really sort of a buyer beware situation with those. I can say that none of those products are offered in the marketplace. If you're buying a plan, if you're an individual buying on your own, and if you buy through the marketplace, you can be assured that all the plans will meet all the rules of the Affordable Care Act, and they will count for the individual mandate as coverage that allows you to avoid a penalty.
Thank you.
All right, now a little bit more on the health savings accounts. As I said, these are accounts that can be paired with a high deductible health plan, and those are plans that specifically offer that come with at least a $1,300 deductible for self-only coverage and $2,600 for a family. If a plan has a deductible of at least that amount, then it qualifies as an HSA compatible plan, and you can open a health savings account to go along with that plan. But I will say, just because a plan is HSA compatible and eligible doesn't mean it comes with an account with money in it. You have to put your own money into an HSA that you can then use to cover costs that are not covered by the health plan. So, for example, the deductible or copays. There are pros and cons to HSAs, but it's worth keeping in mind that there are tax rules that apply to what you can use the money for in paying for your health care services. And there are also additional issues for people who qualify for cost-sharing reductions and for young adults that I wanted to talk about in some detail. Recall that if you buy coverage in the marketplace, you may qualify for premium tax credits, but you might also qualify for what's called cost-sharing reductions, which reduce your out-of-pocket costs. It may lower the deductible, copays, and co-insurance, and even cover some services before the deductible if you qualify for that help. If you do, then it may lower your deductible to less than, it's highly likely that it lowers your deductible to less than $1,300 for an individual plan or $2,600 for a family plan, which means that you don't then qualify for an HSA. But you want to be really careful. It's probably the case that taking the plan with the cost-sharing reductions will be a far better deal for consumers than foregoing that help and enrolling in a high-deductible plan with an HSA. There's a separate set of issues for young adults. Recall that under the Affordable Care Act, insurance companies, whether it's buying on your own or through your employer, have to cover your children up to age 26. But the rules that govern health savings accounts come from the IRS, and they have a different set of rules. So they say in that case that you can only use funds from your HSA to pay for your children up to the age of 19, or if they're full-time students, up to the age of 24. So it doesn't align. If you have a plan in the marketplace that allows you to cover your children up to age 26, you won't be able to use your HSA funds to pay for them past the age of 19 or 24 if they're a student.
So what are some of the pros and cons about having an HSA compatible plan?
Well, if you're someone who is basically healthy and you have significant income or enough money to sock away in an account, it comes with tax advantages. You can make contributions to that account tax-free. You can earn money on the account without paying taxes on it. So there's some tax advantages to having money in your HSA to pay for costs that go with a high-deductible plan. But the risk is it is a high-deductible health plan. So if you're someone who anticipates needing a lot of health care, it may not be the best plan for you to have a plan that has high deductible and requires you to pay out of pocket before coverage kicks in. It also comes with a fair amount of paperwork that you have to justify, make sure that the expenses are allowed, because if you take a withdrawal from the HSA for an expense that's not specifically allowed under the IRS rules, you'll pay a penalty for that withdrawal. So you have to pay attention. You have to be someone who can pay attention to IRS rules and can tolerate a lot of paperwork.
Okay, that's a good caveat. Thank you.
Moving on to cost sharing generally, there are, of course, deductibles, and I'm going to talk in a minute about embedded versus non-embedded deductibles and what that means for consumers. But these plans do, in many cases, come with significant deductibles. And you will know from your summary of benefits and coverage what the deductible is in your plan. It will also detail for you whether or not the plan has co-payments or co-insurance and in what amount. There may be a higher co-payment required for specialists versus a primary care visit, or higher co-insurance amount, like 30% versus 20%. It's easier for consumers to sort of project what their needs may be with a co-payment, to say, I know that I'm going to visit the doctor 8 times this year. It's a primary care visit, so I can figure out what that's going to cost me. It's a harder calculation to make when it's co-insurance, because it's 20% of what, unless you happen to know what your doctor charges. You may not know what that amount will be to you to sort of plan for the year ahead. On the plus side, under the Affordable Care Act, all preventive services that are recommended for you by experts on a panel of preventive services experts, if it's recommended for you, the plans have to cover those services without any cost sharing. So that means the deductible won't apply and you won't have to pay a copayment or coinsurance. Okay, now let's look at what an embedded versus an aggregate or non-embedded plan, a deductible means. Let's take the case of this family, the Gomez family, where the mother and father have relatively low health care expenses over the course of the year, but their daughter, Anna, has significant health care expenses. In the case of an aggregate or non-embedded deductible, each family member's health care spending has to meet the total family deductible before anyone benefits from the coverage under the plan. So in this case, they have to combined spend $6,000 in order to meet their deductible, and coverage will kick in at that point. In an embedded, a plan with an embedded deductible, each family member has to meet their own individual deductible, and then their totals still count towards a family total deductible. So in this case, Anna, who spends about $5,000 a year, will meet her individual deductible earlier in the year and will get coverage starting after that point. The family together will not meet that $6,000, but at least Anna, with her significant health care needs, will have coverage that kicks in after she meets $2,000 deductible. So it's an important distinction to be aware of. If it won't necessarily be obvious on the plan documents.
So how will I know if my deductible is embedded or not? And does it matter?
Well, it does, and it's going to be hard to find out. It's not necessarily going to be on the summary of benefits and coverage. It's not one of the things, as you may know, the summary of benefits and coverage is a standard format for summarizing the plan details, the deductible, the cost sharing, the rules, and so forth. And it's not one of the things that the plans have to include on their summary of benefits and coverage. So your best bet is really to call the plan and find out. It matters, as this example illustrates, if you have someone that has significant health care needs, because in the aggregate case, they never actually get coverage under that plan because their total of all their expenses doesn't meet that aggregate deductible. So if you have someone with significant health care needs, you make out better under the embedded plan, and it's worth calling the plan to confirm and understand how the deductible is applied.
So in the aggregate one, that the Gomez family doesn't ever meet the deductible, even though Anna has all the health care costs, right?
Right, because even Anna's at $5,000, but her parents together only had $750, so they still come in under $6,000. In the embedded scenario, she reaches her deductible and gets coverage.
Thank you.
All right, looking at choosing a plan based on the network. There are standards that apply to marketplace plans. They have to meet network adequacy standards, but they're kind of squishy, and it's really in the eye of the beholder. And in this case, the beholder is the health insurance company that gets to decide, put together a network that they will tell, make the case that it's adequate and provides access to providers who can deliver services provided under the plan. Insurance regulators look at those plans, but you should not assume that just because the plans meet this network adequacy standard that every plan is the same and you'll do fine no matter where you land, because that isn't necessarily the case. You really do need to use the provider directory to confirm that the providers you care about are in network, and be aware that a lot of the provider directories are notoriously out of date, in part because they just don't keep up to date with them, and then in part because there can be mid-year changes that the directory does not change to reflect. A provider may drop out, and the insurer may not necessarily update the provider directory. It's also important when you're looking at plans, considering plans for enrollment, is pay attention to the policies and procedures that apply. So going back to some of the products I was talking about earlier, there may be a requirement that you work with your primary care physician to get to see specialists, or there may be visit limits on particular services like occupational therapy or physical therapy. So if you expect to use those services, you'll want to understand before you choose the plan what rules will apply, how easy it is to get to the specialist you need, and whether or not it's going to cover the number of visits you need as well. And generally, sorry, go ahead.
I'm sorry. So how will I know if my providers are in network?
Well, so there is this directory. It's notoriously out of date, but I guess I would suggest the belt and suspenders approach. I would both call the doctor's office or the providers of the hospital or the HTC and confirm that they're in network. But you need to say specifically not just the Blue Cross Blue Shield plan, but the Blue Cross Blue Shield Silver 2000 plan, like a very specific plan, because sometimes the provider's office will just answer and say, yes, we take the Blues plans, and they may not necessarily take the specific plan you're looking at in the marketplace. So I wouldn't stop there. I'd also call the plan just to confirm and say, in this particular plan that I'm considering, are these providers considered in network? So you can confirm at that point in time that they're covered. That could change later, and we'll talk about some of those issues later on in this presentation.
Thank you.
Okay, so what happens now that you've selected a plan and for whatever reason you decide, oops, it's actually not the best plan for me. I misunderstood the provider, or my provider is not in network, or I actually don't think I can meet that deductible. I should have chosen a different plan. What are your options? Well, different from last year, you can actually change plans during open enrollment this year. As long as it's still open enrollment, which is until February 15th of 2015, you can change your plans even if the coverage has taken effect. That was not the case last year. So if you make the change, if you decide after December 15th, you were automatically renewed in a plan, or you selected as a plan on December 28th, it takes effect on January. I'm sorry. If you select a plan in late December and it takes effect on February 1st, and you decide at some point that you want to change plans, this is the effective dates that will apply. If you make a change before the 15th of the month, the coverage takes effect on the first day of the following month. However, if you go in and make a change after the 15th and until the end of the month, your coverage doesn't take effect until the first day of the second following month. So let's say you change plans, you go in and make a change on January 10th, that coverage will take effect on February 1st. If you make a change on January 20th, the coverage will take effect on March 1st. And generally, changing plans outside of open enrollment is not allowed unless you qualify for a special enrollment period because you've had a change in circumstances, whether it's a marriage or a birth of a child or adoption of a child or loss of your job-based coverage. Those all qualify you for a special enrollment period. The special enrollment period triggers are generally the same inside and outside the marketplace. There are a few that only apply to the marketplace. For example, if you're enrolled or disenrolled in a plan because of an error of a marketplace employee or representative, or if you've had a change in immigration status from a status that it makes you ineligible for marketplace coverage to one that makes you eligible, or if you have a change in income that would newly qualify you for a tax credit, all of those are only triggers for special enrollment periods if you're in the marketplace. Okay, now let's switch over to using the plan you just enrolled in. In terms of provider issues, this is the time to be sure you know if you need to establish a primary care position to get to any other services in the plan. For example, with an HMO, you should work on establishing that, if finding a PCP that's going to be covered by your plan and establishing a relationship with that PCP so that when you need specialty services or other lab tests or something, that you have a way to get to those services with your primary care physician. It's also important to understand the implications of out-of-network care. So recall that another of the protections of the Affordable Care Act is that insurance companies must limit your out-of-pocket costs each year to $6,600 for an individual and $13,200 for a family plan in 2015. If you go out-of-network for care, that does not count towards the maximum out-of-pocket limit. This is different, though, from a tiered provider network. You may be more familiar with tiered drug formulary, so that there's one copay that applies for generics, another for brand name drugs, and then a higher cost sharing for specialty drugs. The same is typically done now, or can be done with provider directory, so that the community hospital might be a lower copay, and the teaching hospital or sort of premier hospital in the community may come at a higher cost sharing. Both of those hospitals would be considered in-network and would count towards your out-of-pocket limit. It's also important to pay attention to the appropriate setting for the care, so making the distinction between emergency services that are truly urgent care needs and what can be addressed in a primary care physician's office or specialty office, not an emergency, whether it's well or sick care. Understanding where to go for care so that you're not charged more, for example, using an ER for routine care. And the summary benefits and coverage, again, will give you your rules around using hospitals and out-of-network providers, so pay attention to those. And then finally, some plans will have what we'll call continuity of care rules that say that if your provider drops out of the network, either because they decided to cancel, they decide to drop out of the network, or because the plan canceled their contract, there may be some provisions for continuing to see that provider for a period of time as if they were in network.
So what happens if my provider who was in network is now no longer in network? And can that happen after I sign up?
Well, yes, it can happen. There's no prohibition, no requirement that plans lock in their provider directory when they offer the plan and don't change it until the next year. So that can definitely happen, and you have a number of options. Certainly, as we said, if it's still during the open enrollment period, you can change plans and find the plan that your provider does participate in and move to that plan, as long as it's the open enrollment period. If it's outside of open enrollment, you still have a number of options. One is that you can, depending on the plan rules, you may be able to still see that provider, but at higher cost sharing. So if you have a PPO, it's an option still to see that provider. You'll pay more out of pocket, and as I said, it won't count towards the maximum out of pocket, but you can at least continue to see that provider with some coverage under your plan, depending on your plan rules. And again, the summary of benefits and coverage will tell you what those rules are. Another option is that you can file an appeal with the insurance company to say that this is the doctor I need to continue to see. There's no appropriate doctor who can meet my medical needs in network, and they may grant you that can continue to see that doctor as if they were in network. And then finally, some states, I talked about how some plans might voluntarily have continuity of care provisions that allow you to continue to see that doctor. Some states have their own laws in the books that require plans to continue to cover services under certain circumstances. So for example, I know in Georgia that if you're a person with a chronic condition or terminal illness and your provider drops out of network, they have to continue to provide coverage for that doctor for 60 days. And there, other states have similar laws, so that may be an option to you depending on where you live.
Thanks.
Okay. Now, we've gone through how to consider the cost sharing. I just wanted to talk about a couple of things that we know sometimes present problems for consumers once they start using their plans. So, as I mentioned, the ACA requires health plans to cover recommended preventive services without any cost sharing, but there are some caveats on that, and that is that in some cases there may be a charge for the office visit itself, if not for the preventive service. Unfortunately, the rules on this are as clear as mud, but what the rules basically say is if the office visit is billed separately, then the insurance company can charge you for it. If it's not billed separately, then it depends on whether or not the primary purpose of your visit was to obtain the preventive service. In that case, they can't charge you for the office visit. If the primary purpose of your visit was not to obtain the preventive service, then they can charge you for it. So let's say you make an appointment for just a checking on a cold or something. You make an appointment with your doctor to get to check on a cold and see if you need antibiotics. While you're there, they say, well, we really should check your blood pressure. Let me do that too, or do a cholesterol screen, blood work for a cholesterol screen. In that case, you would get charged for the office visit, but not for the recommended preventive services of the cholesterol screen.
What about if I wanted a flu shot at that time?
Yeah, if you made the appointment because you wanted to go in for a flu shot, you will not be charged for the office visit in that case. But it does sometimes come down to whether or not, depending on how the insurer bills for it. And if you find that you're getting a bill for what you thought would be a free preventive service, it's worth contacting the plan and finding out and pushing back a little bit. Because as I said, unfortunately, the rules are a little bit murky on this. And we have heard where sometimes people are charged an office copay when they weren't anticipating it. The deductibles are, for marketplace plans, often much bigger than people were expecting. Certainly bigger than you might see in a typical large employer plan. But it's important to know that some services are covered before the deductible. In addition to the preventive services, a plan might voluntarily cover also a few primary care visits or a limited number of prescription drug refills. That will be detailed on your summary of benefits coverage, what is covered before the deductible. And then this is also the place, if you have an HSA, that you can use funds from that HSA to pay for expenses that you would have to pay for out of pocket because you haven't yet met your deductible. A couple of points in the drug formulary. If you find that, again, this frequently comes with the tiers of copay or coinsurance, you want to pay attention to how your factor is covered. It may be covered under your medical benefit or your prescription benefit, so you need to find that out. It's not necessarily the case that the formulary will make that clear to you. You may have to call the plan to confirm that if it's under the medical benefit, it won't necessarily show up on the formulary. You'll also have to pay attention to the rules that apply. So if there's a requirement of step therapy or fail first policies or prior authorization, you'll want to know those rules before and work with your doctor to be sure that you follow the rules or get an exception to that if needed. And know that some states have protections that go beyond the ACA, like they may require prior notice before any formulary change may be made. Again, this is going to vary by state. Nearly all states allow plans to change their formulary mid-year, but they might have some protections around proper notice or can't make the change until you provided 60 days notice for people or something like that. So you'll want to pay attention to those. But there's also an exceptions process required under the ACA, and in some cases states go beyond that to say that if you ever need anything covered that's not considered a covered drug on the formulary, you can use the exceptions process to request coverage of that non-formulary drug. And then finally, the maximum out-of-pocket, as I talked about, you will want to pay attention to what does and does not count towards that out-of-pocket limit. It does not have to include non-covered drugs. It does not have to include out-of-network care. It does not have to include the cost for a brand-name drug if a cheaper generic is available. These should be detailed in the summary of benefits and coverage where it talks about the out-of-pocket limit. There's a box that says what does not apply to, what does this include? And it may say things like it does not include the following things. So you'll want to know that too.
What if I find out one of my prescription drugs isn't covered under my plan and the other prescription drug is at a really, really high cost specialty tier, making the out-of-pocket cost really expensive?
Well, again, if it's not covered, you can go through this exceptions process that is an opportunity to formally request the plan cover your drug as if it was on the formulary. And if it's an emergency or what they call exigent circumstance where not getting the drug would endanger your health or your life, then it's considered an emergency and they have to provide you with a decision on that request in no more than 24 hours after receiving your request. Federal rules also strongly encourage health plans to continue to provide that drug while you're going through that exceptions process, so you don't just drop off and suddenly have no coverage while you're waiting for the outcome of that exceptions process. They encourage plans to continue to offer them, but it's not a requirement. It's certainly something you can request and push for, or may already have available to you, but it's not a requirement. And then federal policy also encourages health plans to cover transitional refills of non-formulary drugs if you're a new enrollee and you're coming into a plan that does not cover the drug you'd previously been taking. Federal rules suggest that plans cover it for a period of time while you go through this exceptions process and may get a determination that they'll cover it. In the case of a high-cost specialty tier drug, you cannot file an exceptions request to say that I don't like the tier that it's on. I'd rather this be at a lower, at a brand name drug copay. That's not something that goes through the exceptions process, but you should know that the out-of-pocket limit does apply. That's considered a covered drug, albeit with high cost sharing. So it would have to count towards that maximum out-of-pocket that I talked about.
Thank you.
Okay, just briefly I want to touch on what to do if something goes wrong. In other words, you're being told that your plan doesn't cover the service you need or you're requesting, or they're not going to pay for a service you received. Most complaints should go to your insurer as a first step. They may have policies already voluntarily, as I said, that they will cover certain circumstances. Or just agree to cover a service. So it's worth checking in there first. But in all cases, I would suggest that complaints go to your Department of Insurance. And there's really two reasons for it. One is that they may be able to fix it. They may contact the plan, and they'll certainly be able to inform you if you have state-provided protections like that continuity of care protection that I talked about. And then secondly, they really do need to hear these complaints to know what's going on in their market with their products. They generally review plan documents from the insurers that say this is what we're offering and this is how we're meeting your rules, and the insurance company the insurance department says, sure, go ahead, start selling. And then they really rely on complaints as their enforcement mechanism to know whether or not that's all working for consumers or where plans are not meeting the rules or providing the promised benefits. So the complaints are an important trigger for the department to know what's going on in the marketplace. And in some cases, they'll even step in and do what they call a market conduct exam. If they get a bunch of complaints about a particular insurer, they may go in and do what's a sort of a formal audit to see how the plan is doing in meeting the state's rules. And then there is also a new protection in the Affordable Care Act for appealing health plan benefit denials. In some cases, some states had this already, but this sort of levels the playing field and makes sure that the rules are fair across all states. And that provides for both an internal appeal, where you can ask the plan for a full and fair review of their decision to not pay for something, for example. And then if you still don't get the answer you want there, you may take it to an external review, which means you ask for an independent third party, not related to the plan, to look at the plan's decision and see if they would agree or not. And this slide just summarizes that process. It's important to know that there are some time frames that apply to the plan and others that apply to the consumer. So plans have to meet certain deadlines in letting you know with a prior authorization request if they approve that or not. If you've already received a service and they're deciding not to pay for the claim you've submitted, they have 30 days to do that. And if it's an urgent care request, they have 72 hours to act on that. Once you get back a decision from the plan that they're not going to pay for something, the consumer has 6 months to take it to an internal appeal. And then again, there are time frames for when the plan must provide a response to that appeal. If you don't like the answer you get there, as I said, you can take it to an external independent third party, and that you have 60 days after the plan provides you with a decision to request an external appeal. And then that decision needs to be given within 60 days of your request. And whatever happens there is binding on the plan so that they have to follow the independent review organization's decision. The web link I have here has a nice step-by-step about how to follow this process, and the toolkit that NHF makes available also has information on how to file an appeal. And then finally, I just want to touch on a couple of examples of the kinds of things that can be appealed. Basically, anything can be appealed to that internal review, that if you get turned down, you can ask the insurance company to reconsider their decision. But in order to move to the external review, which means you have that outside independent organization looking at the decision, it has to be a case of medical necessity, with some exceptions based on states. But largely, it comes down to whether or not the the dispute is around whether or not it's medically necessary for you, and then you can take it to an external review. So, for example, if you go out of network to see a specialist that you say you absolutely have to see because there is not one appropriate for your care in network, or the plan may say that a particular procedure was not medically necessary or that a treatment was experimental. Or they may say that while the plan covers a particular service, whatever it is, for you, Bob, it's not a covered service because it's not something you actually need. These are all things that are can be appealed to independent review, can go to external appeals if you can make the case that it's medically necessary for you. And you'll need your doctor's help in making the case. You'll have to follow the time frames. But it is an option.
So it seems like there's a lot of steps in this process, and I'll need my doctor's help to get them done. Is it really worth my time to appeal it?
Well, it is. It is a lot of steps, and you want to pay attention to the time frames. You will have to get your doctor's help to make the case that it was medically necessary. It's hard to make that case without your doctor's help. But absolutely, it is worth the time. And you know, a study done on appeals some years ago found that in about half the cases, it wasn't that the plan actually made a decision that you didn't need the care and they wouldn't pay for it. It was just a coding error, that the way the claim was submitted had some error, that they called the hospital an outpatient center, or they called the female patient a male, or something that was just the wrong code on a piece of paper, and it was denied for that reason because the boxes didn't line up. It may be a case that they're questioning the medical necessity of something, but you can still prevail with that too, and in the end, you would get coverage for something that was previously denied. You would have had to pay for entirely out of pocket or decide to forego that treatment. So it is absolutely worth taking these steps.
Thank you.
Okay, and that is, well, I'm sorry. Yeah, that is our presentation today. And unless there's any more questions?
No, and we want to thank Joanne again for doing this for us, and we'll post the FAQs on our webpage under the video. Thanks again.
Thank you. Bye-bye.